To have you with us here today for Dr. Professor Rebecca Katz's presentation. So she's an associate professor and director of the Center for Global Health Science and Security at Georgetown University. Hopefully you'll find her presentation today fascinating, asks lots of great questions because she is on the schedule to teach a course here in the spring for us. So hopefully you'll be interested in pursuing that as well. But without further ado, welcome to SSP, and we look forward to hearing you.
All right. So yeah, I'm Rebecca Katz. I'm in MedDens, which is the farthest building you could possibly find from this one. Let me also say, so I'm faculty here at Georgetown. I have a second hat. I work at State Department, but I'm here fully in my academic capacity today. And the disclaimer that you probably have all heard by heart, and I'm not in any way representing the United States government or whatever else I'm supposed to say there. Okay, so what I hope to do is talk to you a little bit about global health security. I wanted to show you some of the cool tools that my research team's been developing that we think is hopefully helping countries around the world address the problem. But I don't ever just jump into it, so instead I kind of start with a little bit of background about the threat. So, what are emerging infectious diseases? What is the threat? What are the international regimes that we have in place to deal with them? I have no idea what any of your backgrounds are. So if this is stuff you have heard before, just somebody make this kind of motion. If I'm also saying stuff and skipping over things that you have no idea about, just let me know. So can I first ask, do I have anybody here who works in health security? Okay, so no like ringers stuff in it. Great. So let me see how this works. Oh, just first, in case you're interested, so I direct the Center for Global Health Science and Security. We are relatively new at Georgetown. We've been working together as a team for many years, but moved to Georgetown about a little over 2.5 years ago. And we're a multidisciplinary team that is pretty much a policy shop working on issues related to how to prevent, detect, and respond to public health emergencies around the world. And there's all this stuff that we work on. So it's a pretty broad range of activities, but all within the rubric of health security. So as I said, I want to talk about the threat and then some of the things we're doing to address the threat. Let me just stand here instead of wandering around. So first, before I get going, most of the stuff I'm going to show you about the things we do are all on our website. So after you're done eating, if you feel like playing along on your laptops, you're welcome to, and I'll show you the links as we go. So let me start with emerging infectious diseases in general. There's been a 4-fold increase in the number of emerging infectious diseases in the last couple of decades. Some of that might be due to reporting, but not that much. Really, we're seeing is an increase in the number of diseases that are popping up, and they're really popping up all over the world. And some of those you've heard about, some of you haven't. I mean, even I have some colleagues at EcoHealth Alliance who is just in the past year discovered a series of new coronaviruses. Coronavirus is the same thing that caused SARS and Merce. So we really are seeing these things all the time. And what's kind of scary about this is the fact that we know a little over 260 diseases, viruses that are in animals that can infect humans, but that's within a universe of somewhere approximately 600, 700,000 viruses. And why this is really scary is that all those emerging infectious diseases I was talking about, approximately somewhere between 60 and 75% of them are zoonotic in origin, which means that these are diseases in animals that are jumping into humans. So we have a bit of a problem. Now there's a whole bunch of reasons that this is happening. So I actually teach an entire course just on this, like what are the factors of emergence for emerging infectious diseases. But it's everything from conflict to land use changes to urbanization, climate change, population growth, migration. And then the viruses themselves, which are, the bugs are always smarter than we are. So all these things are happening, and if we just take a few of them, I mean, just look at population growth alone, right? So we're It took about 200,000 years for us to get to the first billion people on Earth, and it's taken another 200 years to get to 7 billion. So we are experiencing massive amounts of population growth. We are seeing massive amounts of urbanization. The majority of the world now lives in a city. And in the next decade or so, I think that number gets to about 66% of the world's population will be living in cities, including megacities. So these are the cities with over 10 million people in it. So we've got more people living on top of people, and we have more people living on top of animals. So the first thing that happens when population gets a little bit of money is they want protein in their diet. Easiest, fastest way to get protein is chickens. So we now have a whole bunch of more chickens on Earth than we ever had before. So back to this idea of, the next emerging infectious disease is that species jump between animals and humans. We've got more humans living on top of humans. We have more humans living on top of their animals. So we've got all this stuff going around the world. And then we have this wonderful thing of globalization, right? So all the wonderful things that you study and talk about. But it also means that a disease that emerges in one part of the world can be anywhere else within 24 to 36 hours. So this is a simulation, if it's working. Yeah, the red dots are coming. So this was a simulation that modeled if H1N1 had started in Atlanta and spread around the world. And the whole point is that disease travels. This past summer, we passed for the first time 200,000 flights in a single day. So again, while all these wonderful things, globalization, trade, but it also means that we're more interconnected, which means disease can travel faster. And we've certainly seen a lot of this, right? So from SARS, Merce, Zika, Ebola, yellow fever. So we're actually seeing the diseases that you might have heard about, right? The ones that make it to the front page of the paper or website. But I'm not sure it makes it across that we're seeing a lot of it. So the World Health Organization receives every month somewhere between 6,000 and 7,000 signals. They follow up and investigate about 300 a month. And they are doing approximately one field investigation every single day. And if the World Health Organization is doing a field investigation, it means that it's kind of overwhelmed the capacity of the local health infrastructure to look at something. That's a lot. Now, WHO cataloged since 2011 over 1,300 disease epidemics. And they're everywhere. So this includes, again, some things you may or may not have heard of. So chikungunya, Marburg, Lassa, the reemergence of yellow fever, Nipah, Merce, coronaviruses. So there's a lot of stuff going on all the time. Bill Gates has, I think, the largest collection of disease modelers around working for him. And his team tells him that sometime the next 10 to 15 years, it is probable that we will see a large-scale pandemic, so an airborne virus traveling around the world with the capacity to kill up to 30 million people in a single year. I mentioned I'm like super fun at parties. So this is scary stuff, and it's real. Now the super scary thing is, I think that the threat is very real, but the daily stuff we're seeing is tangible, and we're actually addressing these threats every day. So we have the threat of naturally occurring disease. There's also the threat of deliberate use. There is a long, unfortunate history of the deliberate use of biological agents. It exists, and it continues to be a threat. We also have both the good and the bad of science. So over the last 15 years, there have been some major advances in science and technology that both contribute to the threat of deliberate biological events like genome editing, CRISPR, dual use research of concern, things like that. as well as the positive side, so the emergence of what we call microbial forensics and the technologies that exist to help identify and investigate some of these activities. So we've got the good and the bad of science, and then what you guys study all day. So just the geopolitical environment and all the kind of the global context that influences whether an organization or a state might decide to use a deliberate agent. So we have a real threat. It has the potential to kill a lot of people, and it's also super expensive. So as a public health person, I like to think that if I just talk to you about morbidity and mortality, I'm good and we can all go our way. Fortunately, that doesn't always do the trick. But then if you start getting into the economics of this stuff, other people get interested. Fortunately for my world, some really fantastic economists have recently gotten involved in thinking about the threats of pandemics and figuring out what the economic cost would be. And they came up with about a little less than $6 trillion. Now, and if you look at an event kind of like the 1918 influenza from 100 years ago, that's estimated to cost up to 5% of global income. And if you put that into perspective, it looks a lot like the estimated cost of climate change. But you hear about climate change. You don't always hear about the pandemic threat. Now we've got a whole bunch of, there is a global governance regime. One of the things that I spend most of my time on is those international agreements on top, the international health regulations and agreements that are in place for things like sample sharing. But there's then also regional agreements and national policies, and all that then has to actually get implemented at the local level. So we've got a lot of stuff going on at really high level, the 30,000-foot level. How do we think about global governance of disease? And as I mentioned, the one that I like the most, the one that I think is most relevant to this topic is the international health regulations. So there has been international agreements on the book for how to, well, start off very xenophobic, how do I keep your disease out of my country? Since the first International Sanitary Conference in 1851. So as scientists figured out like what was causing cholera, they got together and said, okay, how do I keep your cholera out of my country? So we've had an evolution of these international agreements over time. And in the mid-90s, the global health community kind of perked its head up and said, we actually have a real problem with infectious diseases. You saw the emergence of AIDS in the 80s. You had the emergence of new hemorrhagic diseases, so more Ebola outbreaks, Marburg. There was the plague outbreak in India in the mid-90s. So you were starting to see a lot of this stuff. And the global community is like, you know what? We really do need some type of treaty-like thing so we can do global governance better. Because the bugs could care less about borders. So we actually have to figure out how we coordinate. So there was an agreement at the World Health Assembly that yes, we're going to revise the international health regulations, we're going to make them relevant to our times, but then not really much of anything happened. And in 2002, 2003, there was the SARS outbreak. So you had the emergence of a disease that was zoonotic in origin, circulated in Guangdong province for months. Nobody said anything. And eventually makes its way to Hong Kong, where it then makes its way around the world. And you ended up with 8,000 cases, about 800 deaths. And that event really kind of shook the international health community in that there was no good global governance. There was no way to communicate from country to country. They used a press release on a Saturday. There was no way to kind of make sure that international organizations could use non-official lines of information. which was ever more important as in the world of social media, right? So following SARS, the World Health Assembly revised the international health regulations. They were adopted in 2005, entered into force in 2007. And these new regulations say a whole bunch of stuff. So first they say that every country in the world has to have what we call national focal points. So there's a way for countries actually to communicate amongst each other 24/7. That you need, if you have something that's called a PHIEC, a public health emergency of international concern. If you have something brewing in your country, you actually need to tell the world about it. And you have to do so within a pretty short period of time. So within 24 hours of your national government figuring out that something's going on in your country, you need to tell WHO. Now, it might take a while for your national government to figure out if something's emerging in a village somewhere. But that's the obligation. And there are a couple other things. You have to be able to do this at points of entry, figure out if there's something unusual or unexpected happening. But the agreements also obligated every member state of the World Health Organization, so 196, 196 states parties, to have public health infrastructure. So there's now a treaty obligation that every country in the world has to have the capacity to prevent, detect, and respond to a potential public health emergency of international concern. So in practice, that means that, oh, I think I've tried. So that means that at the local level, so think about a community or a village or something, you need to be able to figure something weird's happening. And you need to take some preliminary efforts to actually control it. And then you need to be able to report it. Hey, something weird's going on. People are dead. People are dying. I'm going to report it up to the intermediate level, so state level, provincial level, at which point they need to be able to say, okay, yes, we acknowledge that we got this report. Something weird might be happening. We're going to do a little bit of investigation. We're going to help to try to mitigate it. And then report it back up to the national level, at which point the national level government has to be able to have the capacity to say, yes, there is something weird happening, no there isn't, we're going to try to control it, and we're also going to report it up to the international level. Now the treaty itself actually doesn't go into specifics about what capacity you actually have to have, but in practice, it means you have to have functional laboratories. Can you do diagnostics? Can you investigate if something happened? Do you have epidemiologists in your country? Do you have rapid response teams? Do you have a preparedness plan? Is it an all hazards preparedness plan? Do you have ambulances? Do you have like all the things you actually then have to be able to do all of this? And it's a treaty obligation. Now it's an opt-out treaty. Under the WHO's constitution, there's an article that says that you can actually create these opt-out treaties, which means that every member state of the WHO is a party to it unless you explicitly opt out. Now, for those of you who look at international law or treaties in any other venue, you don't actually get that very often. The good news is the entire world's a party to it. The bad news is that many of these countries that are a party to it don't actually know much about it. Like they didn't go through the effort to sign or ratify. So, which has been a little complicated. Now, I mentioned there's these things called public health emergencies of international concern. There's a process by which the WHO would declare something. Yes, you have a PHIEC, but there haven't actually been that many. The first was declared in 2009 for H1N1. So this was the emergence of a new strain of influenza coming out of Mexico, and then declared a PHIEC and then later declared an actual pandemic. WHO got in a bit of riff on this because even though the virus met the definition of pandemic, it wasn't. It was based on geography, not severity, and there was a lot of pushback from the international community of like, well, it didn't kill that many people, so should we really be calling it a pandemic? But that aside, the international health regulations were exactly how they should for this. Now, the second ever declared PHIEC was a little odd. It wasn't the type of disease outbreak that we normally think of, but it was done for polio. And it was done for polio because of graphs that look like this. So this is Pakistan, where you had, just as far back in the 80s, you had thousands of cases of polio every year. And then after an incredible push by the international health community, led by Rotary International and then by the Gates Foundation joining them, there was this incredible effort to try to eradicate polio. And wonderful success. Almost. And then you get to like 2013, 2014, and cases start to pop back up. And they're popping back up in mostly non-permissive environments. So the border region of Afghanistan, Pakistan, northern Nigeria, fears of cases in Syria. So really in some of these more ungoverned spaces. So the reason for declaring the FIIC under the international health regulations was to try to focus attention on what could be done. So while it may be hard to get polio vaccinators into the border region with Afghanistan, Pakistan could make sure that anybody who left the country had actually been certified to have gotten their vaccination. So that's the reason for that one coming in place. The third declared FIIC was Ebola. This may be working. Is it working? Nope. Maybe not. Sometimes it works, sometimes it doesn't. If it was working, what you would see is a super cool GIF behind there that would be showing you, as I speak, how each case spread and the incidence while mapping the genome. Anyway, super cool. I'll send it to anybody who wants it. So the third declared FIIC was Ebola. Ebola in West Africa emerged in, I think, in December 2013. A 2-year-old boy interacting with bats in Gekadu, in Guinea, in the forest region, and then spread pretty rapidly in Guinea and then across the borders into Liberia and Sierra Leone. You ended up with 22-ish thousand cases and 11,000-ish deaths. Largest by far outbreak of Ebola anybody had ever seen. It was the first time we'd ever seen the outbreak in an urban environment and a highly mobile population. The virus emerged in 2013, December. It wasn't until August 8th that WHO declared the public health emergency. There are a lot of reasons for that, a lot of which are very political, which kind of speaks to the fact that this is not just health. There are lots of things that are going on. But WHO got in a lot of trouble for this. And there was a lot of call for, is this the right organization? Do they even know how to do emergency management? Do they know how to do outbreaks? Why are they waiting so long? People are dying. You had groups like MSF screaming from the rooftops to anybody who would possibly listen, please come help us. You know it's bad when MSF is begging for the military to get involved. But this was the third declared FIIC. Now, once the FIIC was declared, these declarations then helped to mobilize resources. So a lot of resources started flowing into the region, which in theory helped mitigate some of the effects of the outbreak. But they got, like I said, they got a lot of trouble for waiting so long, which is why the fourth FIIC declaration came so quickly. So when Zika virus emerged in the Americas, this is a virus that had been around for decades, but had never given really anybody much of any notice. But when it emerged in the Americas, there was this weird thing that was happening where there were a whole bunch of cases of microcephaly. So babies born with congenital defects, the small heads you might have seen on the news. And it seemed like there was a link, but nobody at that point actually knew for sure. But WHO wanted to get in front of it, so They declared this public health emergency of international concern even before they actually had conclusive evidence that the virus was linked to the microcephaly. So that's your next declared FIIC, and then there's a whole bunch of stuff that haven't actually been declared FIICs yet. So H7N9 is an influenza strain that is circulating in southern China. This is what keeps me awake at night, and there should be a lot of things that keep me awake at night, but this is the one that bugs me. This is a highly lethal influenza. You think about how easy it is to spread flu or a cold, right? Think about the 1918 influenza. Anybody know what the case fatality was for that? So first, it killed about 50 million people worldwide at a time when people were still traveling by boat. So 50 million people worldwide with a case fatality of somewhere, I think, around 3%. You take one of these, case fatality somewhere around 40%. So the very best thing that is happening right now in the world, in my estimation, is that this does not have sustained human-to-human transmission. So we've got these things kind of brewing in the background. Another one of these things brewing in the background is Merce. So the cousin of SARS. So emerged in 2012. There have been over 2,000 cases. Every year, around the time of the Hajj, everyone gets really nervous again. But so far, we've been really lucky that this disease has not kind of blown up and spread around the world. So we have all this kind of background noise, right? Now, if we go back to the international health regulations, as I mentioned, they were adopted in 2005 and entered into force in 2007, and countries were given until 2012 to fully implement them, to build all that capacity, to be able to prevent, detect, and respond to these public health emergencies. But in 2012, when the first kind of check-in came, about 22% of countries had actually done it. And 2 years later, at what was supposed to be the here's your final deadline, 33% of countries. What do you do? It's a treaty obligation, but it's also kind of like an unfunded mandate. So there was a lot of what do we do? So the global community is like, well, we've got this unacceptably slow progress towards building these core capacities. In part, little secret, not so much of a secret. Ministries of health tend not to be the most powerful ministry in a country. Just saying. Maybe ag, maybe education are below them. And so because it was mostly the Ministry of Health that were cognizant of this obligation, they really didn't have the power to do a kind of whole government, whole society effort. And you also had the national leaders, the heads of states, had no clue what this thing was, even though, again, their countries were a party to it. So this issue, along with a couple others, led to the launch in 2014 of the Global Health Security Agenda. Has anybody heard of this before? Got like one person barely nodding, and everyone else is like, no idea what you're talking about. So in February 2014, the US, along with 27 other countries and 3 international organizations, launched this thing called the Global Health Security Agenda. It's on a horribly snowy day, impossible to get there, but the point of this was to do a couple things. To raise this issue on the political agenda, because if nobody knew about it. You need to actually get people talking about it, understanding what these problems were. And the other major thing that it was supposed to do was to marshal resources. So, okay, we got a problem, how do we pay for it? How do we actually provide countries who need it with the resources to build this capacity, because it's a shared problem, right? So again, the disease that emerges in one part of the world can be anywhere else. So it did that. It broke things down in it was called 11 action packages. It's badly named. And here they were, that countries were supposed to build their capacity around zoonotic diseases and the ability to quickly do an immunization campaign, to have biosafety and biosecurity, to have laboratory systems that could actually detect diseases, a surveillance system so you could figure out when something was happening, a reporting system so when you figured out something was happening you could report it to the right people who could then help you in the response, to actually have a workforce capable of doing all this stuff. So there was this idea that you were going to actually build these capacities. Now, that was the idea, to push this stuff forward. But then I link this back to the international health regulations. So those action packages became part of a monitoring evaluation system by the WHO to think about the capacities that countries should have had in place and need to have in place for our collective well-being. And there's a 4-part system to WHO's monitoring evaluation. So the first is annual reporting. This is kind of written into the treaty, and everybody has to do a little bit of navel gazing and report every year of how am I doing. Fine. What we found coming out of the Ebola outbreak, and what we kind of knew before that, was that these are not always that accurate. So they added a couple other things. So in addition to your voluntary reporting by countries, there's also a process for after-action reviews. When there's an outbreak, there's a process now to actually capture, in theory, your lessons learned or at least identified. They now do simulation exercises, but 2 and 3 are voluntary. And the 4th thing that was put in place was something called the joint external evaluations. This was an outgrowth of the Global Health Security Agenda, which put together this elaborate monitoring evaluation and assessment plan that then became part of the IHR. And joint external evaluations are when an external team of global experts come into your country, assess where you are along a certain number of indicators, 19, and then spit back a report, and then the country then says, okay, these are our priorities from all of this. And these are voluntary. Now, there's been a ramp up in actually doing these things. This is an old slide. There's now 81 countries that have actually participated in this effort. But the idea behind this effort is not just that, and I should mention there's a little bit of controversy because this was an outgrowth of the GHSA, and GHSA is a US initiative. You had several countries that were a little reticent to engage. So Russia, China, Brazil have all kind of been very vocal about not wanting to engage in this process. Now, there's a saying in epidemiology that surveillance without response is just documentation of misery. So it's great that you would go in and have this team do an evaluation of where you are in terms of building your core capacities, but then so what? The whole idea is that you then have to do something about it. So there is a process in place, it's called the National Action Plan for Health Security. So you're supposed to take your external evaluators from around the world are supposed to come in, help assess where you are, then they spit out a report, and then the government gets together and says, great, we have this report, now let's prioritize the things that we actually care about, that we want to do, and now we're going to create an action plan that is costed because we got to pay for it. Great. Yay. Costing's hard. About 9 years ago, my research team started working with countries to figure out where they were in terms of IHR implementation. And we wrote hundreds of pages long landscape assessment documents. Beautiful, nobody ever read them. And what became very clear to us about a decade ago was that the countries could not build a business case for themselves because they just had no clue what anything cost. So we started an exercise of actually trying to figure out how to cost public health infrastructure. And early on, we were doing all sorts of crazy economic modeling. Realized we actually don't need any of that. We actually just need to figure out what something costs. So years of pretending that we were a lab in Rwanda. What does it actually cost to get lab equipment shipped there? What does petrol in Malaysia cost? So we were starting to go through this process as well as trying to actually define if WHO says you have to have an indicator-based surveillance system, what does that actually mean? And how do we break that down so we can break it into stuff that you could then cost? So we did this for many years, and about a year ago, we posted online a IHR costing tool. So before there was a multi-week process, probably multi-month process to try to help countries figure out how to cost stuff. We can cost your JE in an hour. It's not perfect. It's an order of magnitude cost, but it's now being used by countries and some of the donors to figure out what are we getting ourselves into here. And it's kind of cool. So if you want to play along, I'll do it with the slides. I also have to let the web links up. But you go in, you say, I want to do this. We have it in a couple of different languages right now. I think actually just French and English are up. You pick a country. You picked Kenya. You go and we don't save anybody's data because that's, we felt that countries would feel better about actually using the tool if they didn't think somebody was saving their information somewhere. So it's a one-time thing, but you can download your session onto a local computer and re-upload it. We also provide all the back-end spreadsheets, and what we found is that some of the more sophisticated users, so the World Bank uses this tool, but they use the back-end spreadsheets. They don't use the pretty user interface. But you go in, you then enter your JEE scores. You then pick whether you want to. JEE scores are measured from a 1 to a 5. 1's the worst, 5's best. You can either score, I want to go from a 1 to a 2 or 2 to a 3, or you score, I want to go to a 4 across the board. We actually don't cost 4 to 5 because it's too country specific. And then you customize it a little bit. You put in some information about the administrative structure of your country, how many tertiary healthcare facilities do you have, things that require point-of-care diagnostics. You enter in some basic cost assumptions. We pre-populate everything, but the idea is you go in and override it. So what does a mid-level Ministry of Health person in your country make? What's their salary? What's per diem? So it's stuff, the kind of costs that come up over and over again. And then it takes about an hour. You enter in your costs along the 19 indicators of the Joint External Evaluation. And at the end, it spits out your 1, 3, 5-year costs, startup capital, recurring, you pick your currency, and with a little bit of data visualization so you can muck around with what are your largest cost drivers. And then if you don't like them, you can actually then go back in and fix it and see what else you get. So it's kind of, and then the ability to kind of export everything. So that's one of the tools that the team's been working on, and we're really pretty excited about it. And it's also really neat to see people actually use it. The other tool that we have designed and also put online, so again, if you're following along, it's tracking.ghscosting.org, is we realized that nobody was keeping track of who was spending money on what. Now, in every other part of global health, there is some type of mutual accountability framework for who is donating, who is actually delivering on it, and a way that you can then start to see, like, hey, 100 countries are spending money in Kenya on HIV, but nobody's spending any money on HIV in Uganda, right? You can start to visualize that and make decisions, but nobody was doing that in the world of health security. So we built it. It's a work in progress, but you go online. First, we track the JEE scores as they come. So this is what it looks like. So green's good, red's bad. And then you can also look at them by specific indicators. So this is for antimicrobial resistance. So you see a lot more red because people are really struggling with how to address that. We built in an indicator. This is a metric that looks at combined financial resources and need as defined by the JEE score. So again, really very simply to get a quick look at, okay, which countries actually need a lot of help? Who's not already getting the resources that they require? And then we break it down. So you can select you can look at across all the indicators of health security, or you can say, I'm really just interested in who's funding laboratory capacity building. You can then look at different regions of the world. So, so doing a presentation in Barbados. So here you go. This is specifically looking at, if I remember correctly, emergency operations funding in the Caribbean. And then if you click on any given country, you then click on the funding details, and you get a pretty detailed breakdown based off of what's committed, what's been dispersed over the last 4 years. We break it down, we code by the element, whether it's prevent, detect, or respond, or other. We then also break it down by each of the core capacities, and then with a line list of who the funding agencies are, as well as we try to capture in-kind support as well. When you get to this, if you hover over the histograms, it then pops up actually who the funding agency is. You can go back and look at that again. And then we built in a little bit of network mapping too, so you can start to, basic analyses of figuring out, okay, what are the patterns looking like? Is the Bill and Melinda Gates Foundation funding 80 countries? Is Costa Rica only getting money from one country? Like, what do those relationships start to look like? And then again, just some line items of like who are the largest funders, who are the largest recipients. It's a work in progress, and we are constantly kind of updating the data inputs to it. But we're hoping that this will actually really help the community in terms of figuring out their what needs to be funded by whom. So both showing the good news stories as well as identifying some of the opportunities. And then, as we get more data, you can then start doing some really neat analyses. Like, does money have the amount of money we drop into a country actually have anything to do with what their capacity is like? If not, what else? Like, you can start to imagine what those regression models might look like. And they've never really been done before, because we haven't had the data. Which gets at, because we're now starting to see data come out of countries, we can start doing some of these analyses. So, we did a quick run of just looking at external evaluation scores versus self-reporting. Not surprising that self-reporting tends to score much higher, but it's consistent. So but actually being able to map that and show those relationships is what everyone kind of thought, but actually having the data show it. The other thing we've been doing is correlation matrices. So can you correlate, is there a relationship between the scores that countries are getting for health security and every other indicator of global health? And what we're finding is, yeah, so it's pretty highly correlated with your WASH system, with maternal child health, with all the other things that we tend to look at. But being able to document that has been kind of neat. It's also inversely related to development assistance in health. But yeah, there you go. So some of the matrices, and this work has been just published a couple months ago. The other stuff we were doing, so online tools. I do a lot of work in the deliberate biological space, so bioterrorism, biological weapons, stuff like that. And what we found was, so when I talk to health people, clinicians, anybody works in the public health space, they get that there's a really huge, that the biospace is complicated. They get that, they live it. But when I talk to folks from other sectors, particularly the security sector, a lot of times we were getting back conversations of like, well, there's a list, so we'll do a really detailed plan for anthrax and smallpox and be done with it. And you're like, that's great, but bio's really complicated. So it's a little bit of a party trick, but we published it in Lancet, so it's okay. We created an online model, an online tool where you can go online and play with it. It's at bioscenarios.talusanalytics.com, where we came up with a model of 22 million different bioscenarios. Actually, we started with 36 million scenarios, and when we reduced by the non-rational combinations, we ended up with 22 million. And these are non-agent-based scenarios. But you can go and you can play with it and be like, hey, tell me a scenario where I would have severe mortality, airborne, starting in a non-permissive environment that requires full personal protective equipment. And you know, how many millions of scenarios would you get with that? So it's kind of an interesting way to engage people and have them kind of understand the breadth of the threat. The other thing we've been doing is, specifically in the deliberate biological space, is looking at preparedness and response. So, let's take West Africa Ebola. If there had been a deliberate component, let's say Boko Haram had claimed responsibility for just a handful of cases, what would that have done? So we interviewed most of the IOs and NGOs that responded to Ebola, asked that or a very similar question. And somewhat frighteningly, the answer is that with very few exceptions, and there are some exceptions, but with very few exceptions, most of the humanitarian disaster response community pulls out. For a range of reasons. One is very simple as insurance. If you have a volunteer physician working for Save the Children, they are protected against act of God. So if they get Ebola and die, they're protected, but not acts of war. So how do we start to think about that? Like, what else would be different if there was if suddenly the outbreak you were responding to is deliberate? So we've been working a lot on these questions, and one of the things that we did was we tried to map who the stakeholders would even be, because the community wasn't even sure. So what we did was we created this is a notional epidemiologic curve of here's an event as it could play out, right? So you have the case identified, the agents identified, there's a humanitarian response, maybe you're suspicious of a deliberate use, everything from you're asking for assistance, there's might declare emergency, ongoing response and recovery. So all these different steps that you might have during an event. And then what we did was we tried to then map each of those steps to who within the international system, which UN organization would be playing, as well as, you know, which parts of an affected member state, the NGO community, non-IOs, private sector, and then mapping those to their mandate for action. It's kind of a cool tool because then if you click on that thing, you actually pops up the document itself. But this is what we found. So we then took that and then we mapped it along these axes of public health and medical, humanitarian, safety and security, and governance and policy. So who the actors were and what they were doing, again, at each of those different stages. And we end up with stuff that looks a lot like this. You get a lot of organizations that have a lot of mandates to do something, but there's nobody here. There's no connective tissue. Because of that, I think we continue to show it. But also something you kind of knew, but actually being able to map it and show this visually to people has been quite helpful. So one of the things that we're working on now is we're going to run a tabletop on the Emergence of the Munich Security Conference this February. With it was originally supposed to be for current leaders, and for all sorts of political reasons, we decided to go with former. So Grove Brundtland, who used to be the Director General of the WHO, will play the WHO Director General. I think there's discussions with Ban Ki-moon to play the SG. So being able to actually have conversations at that level to start figuring out how do we solve that? Who's in charge? And do we need entirely new systems, or are there incremental changes that we can make to existing systems to be able to address the threat of a biological event? So we got that going. Also doing some work mapping how do you even request assistance during a deliberate biological event, which there's some language in the Biological Weapons Convention on this, but 40 plus years in, nobody's actually figured out how to operationalize it. So another line of work that we've been up to, and then actually trying to articulate that gap. And the last thing I mentioned, one of the other projects, well, two other projects, one that we're working on is on urban pandemic preparedness. So I've been talking a lot about global governance and this kind of all this stuff happening at the WHO level. But one of the things that I'm really excited about is we're now trying to think about how to engage municipal level leaders. Because this is great, I can talk to you all day about a treaty. But at the end of the day, if there's an outbreak, it's going to be like city leaders who are going to have to figure out how to conduct a quarantine, figure out where their vulnerable populations are, manage the first responders. All these things that could either be done really badly or really well. So in 2 weeks, we are going to Bristol, UK for the Global Parliament of Mayors. Who knew, right? So 100 mayors from around the world are getting together, and one of the things that we're presenting is the issues about urban pandemic preparedness and having them vote on a series of resolutions. So it's very similar to what's been done, you may have heard about in climate change, and kind of networks of cities that are getting together to think about best practices, shared resources, and trying to move forward the agenda from their perspective. So that's one of the kind of the newer areas of work that we're involved in, but a lot of fun. And then finally, this is a kind of a new area. Now I've been working on something, it's had different nomenclature, but something related to health security for at least 20 years. But we haven't really had a community focused on it, and now we do. We're about a decade into actually having a real community. So we are organizing the first ever international scientific conference on global health security that is scheduled for this coming June in Sydney, Australia. And so it's kind of the first step towards creating this community of practice of scholars from around the world, as well as the opportunity to bring together both scholars and practitioners. So we're really, really excited about it. So if anyone finds themselves in Sydney in June, or can convince somebody in the university to send you there, that'd be great. Georgetown's actually one of the institutional sponsors for the event. So super excited. So anyway, so that's some of the work that we're doing. As I mentioned before, all those tools we post on our website, and if you're interested, go take a look. But let me end there, and this is where I'm also supposed to replug that if you're interested in this stuff, one, I'm delighted to talk to you about any of it. But also we're gonna offer a course next semester, I think Monday evenings. What's kind of fun is, so this is a course I've taught I taught for a decade before coming to Georgetown for Masters in Public Health students. And so I've been revamping it a little bit to make it a little bit more appropriate for the Security Studies program, but also Ambassador Jimmy Colker, who was, had a really interesting career. He was ambassador in Uganda, startup of PEPFAR, and did some really neat work in terms of, and is really one of kind of the US's main health diplomats. Did some AIDS work for UNICEF, and then ended his career in government as the Assistant Secretary for the Office of Global Affairs at HHS. He keeps asking, like, how do I get more involved with students? So we've actually designed a course-long simulation, and he'll come in a couple of times during the course of the semester and help run the simulation. And kind of play your national security advisor. So anyway, for those who are interested, I would love to have you in class. So I've been talking nonstop. Let me stop there. Does anybody have questions? Yeah, please.
Steve Reed, first semester SSD. Have you seen World War Z, and what was the comedy zombie apocalypse?
So yes.
Yeah. But you sort of mentioned the mid-90s with the coming plague and Warren Garrett. I mentioned World War Z, and then you can go back and look at the Black Death. The short question is there an actual pace that you could be infected with X and it would kill you? And then to take that a step further is, say something emerges that is as deadly as the Black Plague. I mean, what's the thought been given to something like that in the sense that it'll go worldwide, but where will it get stopped?
So short question, but it's like a really, really long answer. I think So, World Health Organization has something called something they call the R&D blueprint, and in that document they identify a number of kind of the diseases they're most scared about, and the idea is that so for something like Nipah virus, which is anybody saw the movie Contagion, that's what it was based off of. The things that we're scared about, like how do we actually focus attention to be able to create a medical countermeasure? So the drugs or vaccines that you would take against Nipah, and how do we get them quickly? So there is that list. There are organizations like CEPI, which is the Coalition for Ending Pandemic Initiatives. I'm getting the acronyms maybe wrong, but so there's a lot of money that's now flowing into this creation of vaccines and other medical countermeasures. But on that list that WHO has, they also have something now called Disease X, and that's for the thing that might be the zombie apocalypse. Who knows, right? So, do we have an answer to how to stop it? Not entirely, but I think the thought process is that the very first thing you need is the capacity to figure out that something's going on. So you need each country to basically have functional public health infrastructure and ideally functional healthcare infrastructure, so you can detect that something's happening, start to identify it. And the kind of theoretical framework in this space is it's an epi curve, and the idea is that if you don't detect that something's happening until it's already spread around the world, then everybody dies. If you can figure it out that something's happening really early on, then you can start to take those mitigation efforts and you can save a lot of lives. And even better, if you can figure out the thing that's going on in the animal community even before it jumps to people, then everybody's okay. So, wow, okay, yeah, please.
So, when you fly to Taiwan, there's a video that's shown for every flight that's 5 minutes long that talks about your social responsibility to self-identify as a sick person. And it's the only place I've seen with that type of video, including the United States doesn't have a similar video. But control measures basically include checking for temperature, and that's it. So people can just take an aspirin and get right through.
Yeah, that's the way that you're going to beat those thermal scanners in any airport.
Is there any discussions about trying to increase education on social responsibility to identify yourself? Because as we saw even with the Ebola outbreak, we had people in the medical profession with a lack of social responsibility to self-identify as a sick individual.
I'm back on you on that characterization a little bit, but I think it's a really fascinating question, and health communication, risk communication in general, and crisis communication in particular is something that the public health community has not always been terribly good at. And I think that what's really fascinating to me is the messaging for Taiwan. Different messages resonate with different populations and different governance systems. I've actually done a bit of work looking at the issue of quarantine and what works best based off of what type of system of government you're in or what your trust of government looks like. So I'm not sure the message would resonate as well on a flight into some JFK about it's your responsibility. I mean, it's a little bit like. This stuff is a little bit like jury duty, right? Like nobody likes jury duty. We all do it because it's our sense of, because we have to, but also because the language is it's your sense of responsibility and part of being part of a community and democracy and all that fun stuff. But we have a ways to go in terms of getting to the place where there's enough trust in the system to be able to say, trust us. If you tell us you have a temperature and we may quarantine you, trust us to ensure that that quarantine will be, will protect your civil rights as much as possible, that you'll be fed, that you'll have internet connectivity. So all the things you would do to make a quarantine less difficult, I don't think we're quite there yet to be able to have that type of messaging.
So what are countries doing, organizations, to kind of contain graveyard sites of deceased bodies, so to reduce the likelihood of weaponizing?
Yeah, I don't know. I mean, again, another good question. Good news is, most diseases are not carried on corpses. Ebola is. And we're not entirely sure for how long. Maybe 6 months, maybe 2 years. It's not entirely clear. So a big part of responding to an Ebola outbreak now is using safe and dignified burials. So burials in a way that respect as much as possible the local culture, but also safely. I don't know actually, but I think I've seen that movie.
Yeah, there's like a lot of different references that.
It's like the latest, like Jack Ryan.
Yeah.
Okay.
The latest one, yeah.
Yeah, I don't know. Okay, you're all making me scared. Yeah.
So first, I just wanted to thank you and commend you for creating tools with research, because having worked in an NGO that related to health and food security, like the dearth of tools that can be applied is noticeable, and that's a huge help. And I feel like in research, it frequently doesn't transition into the tool building. So I wanted to commend you for that. Secondly, question about the funding issue. I'm curious what you think, given the limited funds, what is the optimal distribution or place for the US government in particular to inject funding? So take Zambia, for example, 85% of US foreign aid to Zambia goes to health issues, PrEPFAR, stuff like that. Is that the right way to be spending our foreign aid? Should we be looking more at an international level, more at a hyper-local level?
So there's a couple ways I can answer that question. It's a really good question, and I think it's one that there's never a perfect answer to. So under the Global Health Security Agenda, the United States has, and there was a $1 billion supplemental appropriation. The United States picks 17 countries. Well, 31 countries, but only 17 get money. The rest get technical assistance. For support across all the JE indicators. I think there's really, so that in of itself, that question, are those the right 17 countries? I don't know. If you just looked at hotspot analyses, where we are most likely to see the next emerging infectious disease, and maybe you superimpose that on healthcare infrastructure and governance, those are not the same 17 countries. But the US, every country chooses the countries that it provides economic assistance to in different ways. And there's a lot of other factors that go into that. So I personally think it's probably worth taking another look at where we're giving the most money to which countries. But there is, it's not just the health issues, there's all the security implications involved in that too. Now, to back on the research side, one of the things that we are actually working on this week, there's a lot of really interesting questions being asked by organizations that do have a lot of money, that do vertical programming, so specifically like your AIDS, TB, and malaria programs. Can any of their funds actually also support some of these horizontal systems? So it's been much less sexy to say, please fund the public health infrastructure. It's a horizontal system. It doesn't, there's no good picture to put on the cover of your funding magazine, right? Because the very, very best thing that can happen is absolutely nothing, which is not an easy argument to make to a minister of finance or to another donor. But some interesting questions that are currently being asked of, how much of PEPFAR, the Global Fund, or the President's Malaria Initiative, how many of those activities can we also think about system strengthening in general? So this week we are doing a project for the Global Fund to actually take a couple of pilot countries, map the projects they are doing for, say, malaria in Vietnam to each of the JE indicators, just so they can start to get a better sense of how much of what we're doing actually could be usable if the next horrible zombie apocalypse happens. So it's a complicated answer to your question, because I think it requires a little bit more thinking. Yeah, please.
In recent years, there have been a number of heavily hyped pandemics that have not really fully been realized, SARS, swine flu, etc. Do you ever worry about a boy who cried wolf problem where people just stop taking these threats seriously because they don't come to fruition?
I think people are always worried about that. And that gets back at that risk and crisis communication. Like how do we scare people enough, but not so much? So this is actually, let me take this moment for my PSA announcement. If you have not gotten your seasonal flu shot, please go do so. I think the university offers them for free. 80,000 people in the United States alone last year died from seasonal influenza. So go get your flu shot. But right, so I can tell you that, right? But did I now just scare you into doing it or not? I don't know. H1N1 wasn't that bad, the 2009 H1N1. But I don't know, my kid got it. He was 18 months at the time. And that was pretty bad for me. It was pretty bad for him. So there's also this kind of weird juxtaposition between, what something looks like at the policy level and what it means to be an individual affected with it. So I don't have a good answer for you, but you get your flu shot. Yeah.
Dr. Katz, thank you again for coming today. My name is Paul Gill. I just wanted to ask you kind of a two-part question. So one,
okay, ready.
For the, what is kind of hypothesized for the next zoonotic outbreak? Do you expect to come from domestic animals? I know you really harped on poultry farms and.
I'm gonna just quick bats.
Bats. Okay.
Yeah. So the second PSA is don't play with bats.
Okay. So, and then my second question was, how worried should we be about rising tick populations?
Rising tick?
Tick populations in the U.S.
A lot of you worry about Lyme disease.
Lyme disease.
Yeah.
So I'm I don't know.
I threw out bats. Who knows what the next thing's going to come from? But bats, fruit bats, other bats. Yeah, bats. Mixed up in. There's all sorts of modeling that's done about what's going to cause the next disease. What should we be worried about? Climate change alone, land use changes. The fact that the latitudes for which Aedes aegypti are present, the mosquito that carries all these horrible, so everything from malaria to chikungunya to dengue to yellow fever, the climate change is changing the areas, the geographic regions where that vector is present. If you cut down more forests, where do the deer go? The deer that are carrying the Lyme, the tick that carries the Lyme disease. So all those things are things to be worried about. So I think, yes, in the things that keep me up late at night, Lyme's not the top of the list. Tick-borne diseases aren't the top, because I'm much more worried about the things that spread by respiratory.
Like canopy. Like canopy.
There you go.
Ma'am, you spoke a lot about creating a system at an international level that helps us all sort of be resilient to naturally occurring diseases. But I guess the thing I worry about is the proliferation of dual-use tools like CRISPR, where nefarious users can not only be deliberate in spreading it, but deliberately engineer diseases to be drug resistant, or sort of hide the indicators that we typically use to identify diseases, or give them certain attributes that they wouldn't necessarily have. For instance,
everybody feel better yet?
Airborne. And so I guess my question is, how do we build the international system like you're talking about to be resilient to deliberately engineer diseases, particularly diseases that might be engineered to beat the system we've made?
Right, so I think, you're raising some really scary threats, very real threats. I'm a treaty girl. I like the Biological Weapons Convention. I might be the only person to say that publicly. But I think that we have mechanisms in place that are adaptable to address these evolving threats. The BWC is one of them. This past August, there was a 2-week series of experts meetings a couple of days were spent on specifically some of these S&T developments and how do we bring the international community together and use our international structure to address the threats. Is it perfect? No. But I think that that's one of the ways at that level that you can do it. There's also, if you think about that triangle from international agreements to local implementation, FSAP regulations. So we have a lot of stuff at the national level to try to start getting at some of these threats, but they are not perfect. And there's a lot of disagreement about should there be, are these the types of threats that are best regulated at the national level, or should there be a different level of international scrutiny? Or is it just research level and the journals are the arbitrators? I don't know, but there's a lot of interesting debate right now. Yeah, please.
Thank you for coming to speak, Dr. Katz. Along those similar lines, are there top technologies or emerging technologies, whether in the viral realm, the nanotechnology realm, that you think are going to assist either the policy side, the prevention side, the assessment, the response, kind of just the whole, either biosafety or human infectious diseases?
So with the caveat that I'm not a tech person, point of care diagnostics and universal flu vaccine. I'll take those two. Those are really high on my list of, wish list. But I think the ability, point of care diagnostics, or even at home diagnostics, depending on where you are in the world, much better surveillance that can actually pick up AMR issues or any disease anywhere, and a system to actually integrate that data. And gosh, a universal flu vaccine would be really nice. But also the ability to quickly manufacture medical countermeasures, which we really can't do right now. So something, and so the platforms for development, manufacturing, and distribution. That I would stick with those. Thanks for coming. Oh yeah,
Sorry, I have a follow-up question. In terms of manufacturing, is it all within the United States or is it outsourced? Because now I'm thinking of cybersecurity issues of getting smaller pieces from outside countries, but how's it go with vaccines?
You should be worried about that.
Okay.
I said I'm super fun. I worry about that. I think if you think about the corporations that currently exist who have manufacturing capacity and where that manufacturing capacity is located, there is not a lot of that that's in the United States. And there is some, but not a lot. And one of the things that I think about is, in the case of a true international emergency, how much of that would be nationalized? If I ran the world and I had a manufacturing plant in my country, even though the corporation was based in New Jersey, but the stuff's being made here, thank you, I'm gonna take that for my population first. So I think that's, yeah. So just add that to the long running list that we all have of things to keep us up late at night. On that note, let me stop there. Thank you guys all for coming. Thanks for listening, and come ask questions or take class or just keep it on your radar screen.